for example. And we have to thank him. I have to say he's one of the greatest neurosurgeon in Morocco in this field, education through webinar, through internet. Thank you, Fed, for all that.
Welcome, welcome. My pleasure.
And I think I don't know if we can start with you. Give us the.
Yes, yes.
It's possible now.
Yes, we are now online with the new webinar of the Morocco webinar series. And our host is Professor Naji El Abadi, the director of the Morocco webinar series. Welcome to all speakers and panelists. And Professor Abadi, you have the mic.
Thank you so much, Fahd. So, dear friend and dear colleagues, we are without doubt living as you know very well through global health history, and we hope that this weekly webinar, at least this one is the third of the second series, but the 26th since we began in last March, allow us to stay connected connected and remember that we may not be in the same boat, but we are weathering the same storm. So together we can continue to strive for our goal. That means to treat our neurosurgical patients anywhere or anytime, and provide educational program to our young neurosurgeons around the world. So it gives me a great pleasure today. First, allow me to express my thanks and welcome to our friend Professor Mehmet Zilili from Turkish, Professor Keki Türker from India, and Professor Said Hirmani from Morocco as speakers. But also thanks to our panelists to accepting our invitation, Professor Nicolas Kiev from Ireland, and Professor Wissam Sobhi from our great friend from Tunisia, but I know he works in Arabia Saudi, and our friend also Professor Nizar El-Fatimi. So it's always a great pleasure to meet all my friend neurosurgeons during this hard time. I'm so glad to be able to moderate this webinar with my friend, Professor Abd Hakim Lakhdar. Today, he is, you know, the president of Moroccan Society. And the topic chosen today is about spine, as you remark, because our honored speakers are the great experts in this field. Without delay, welcome again. Thanks for accepting our invitation. And I give the floor to my friend, Professor Lakhdar, to introduce our first speakers and moderate the webinar. Thank you so much for to be with us today.
Thank you, Professor Abadi, for all the efforts you are doing to maintain this very important program of weekly webinar series of the Moroccan Society of Neurosurgery. Thank you, Professor Dr. Darqawi, for all the efforts and the technical support you are and the job you are doing for these webinars and all the efforts. Thank you for our speakers and panelists. Before starting, I will present Dr. Nicolas Pive, who is the panelist for I think the first conference, the first speaker. Dr. Nicolas Pive is currently a consultant neurosurgeon and spinal surgeon in Belfast, Northern Ireland. He is a member of the WFNS Spine Committee and the World Spine Colon Society. He is a member of executive board of the World Spine Colon Society. He is a member of Asian Congress of Neurological Surgeons and Core Educational Committee faculty member. Also, he is honorary member of Pakistan Society of Neurosurgery and the Royal College of Surgeons in England. He is also a member of American Austrian Foundation Open Medical Institute and General Medical Council, Bulgarian Society of Neurosurgery, Bulgarian Medical Union, and Bulgarian Society for Cell Biology. Regarding his academic activity, he is a member of the section editor of World Neurosurgery Journal and member of board of Neurospine Journal, board member of Asian Journal of Neurosurgery, and board member of Nepal Journal of Neurosurgery. He is involved mainly in mini-invasive neurosurgery, complex spinal surgery, and spinal trauma, neuro-oncology, traumatic brain injury, neurovascular surgery, and skull-base surgery. And also, his practice is mainly focused on this aspect, and also his research is focused on this mainly on the degenerative spine, minimally invasive spinal surgery, endoscopic spinal surgery, traumatic brain injury, metastasis, and spinal tumors. He had many fellowships in complex spine and minimally invasive surgery in 2014, and also fellowship of in Ohio State University, Columbus, in the United States, in minimally invasive neuroendoscopic surgery, and many other fellowships, and he has many publications and participation in international and regional meetings. So thank you, Dr. Nicolas Pive, for in accepting this to animate this session. And now, could you please present Professor Mehmet Zilili and give to start this his conference. Thank you.
Hi, everybody, and thank you so much for the nice presentation. It's an honor and a pleasure being with all of you today. And it's my great honor to present Professor Mehmet Zilili. Mehmet is a teacher for many of us, and he's tracing the path which we follow. So he, if I have to present in details, we have to talk about him quite a lot and quite long. His achievements are quite many. Currently, Professor Zilili is chairman of the World Federation of Neurological Society Spine Committee from 2017. He is chairman of ISMIS Turkey. He is honorary president of Middle East Spine Society. He is executive committee member of Asian Congress of Neurological Surgeons. He is spine section editor of the World Neurosurgery, and he is deputy editor of Neurospine Journal. So Mehmet has many past achievements, and he has organized and he is organizing a lot of scientific events, which we are very pleased to participate in and to enjoy the great educational value of all this. He has many awards in the past, and he continues to educate us, and is one of the great teachers that I know. So pleasure presenting him and be with him today. Thank you.
Thank you, Nikolai. Thank you, dear friends. I can share my screen, but you must enable me to share the screen.
Yes, please try again, please, Professor.
Okay. Now I'm
good.
Okay.
Good. Yes.
Yes. Today is the topic is a quite popular topic, tube-guided decompression for lumbar and cervical problems. I will try to give some general information, and then my own experience I want to talk about. As we look at the type of minimally invasive discectomies, microdiscectomy is still a gold standard. Many spine surgeons are still using that, and they are happy with that. I'm not against this, but there are some other advantages if you use some other minimally invasive techniques. Transforaminal endoscopic discectomy is, I will try to give some outlines of it, but it has somewhat shorter indications and not that large. Interlaminar endoscopic discectomy, there are mainly two types. One is the microendoscopic discectomy, which I will explain you, and then the so-called full endoscopic discectomy, or water irrigated system usage for interlaminar endoscopic discectomy. If you look at the literature, although there is one historical description in 1975, but the real invention of microendoscopic discectomy is in 1996 by Foley and Smith, US neurosurgeons. They have done it with muscle splitting and tubular retractors, and they've used endoscope at the beginning. Their first series was published in 1998. Then some others have published that. However, since most neurosurgeons are familiar with using opaque microscope system, it was then modified in USA to work through tubes in variable lengths and diameters. And instead of endoscope, they have switched to use microscope inside the tube. So then they called it inside tube microdiscectomy. What is the difference with conventional microdiscectomy? They claim that with that tube system, you dilate the muscles, so then you make less damage to the muscles than you do with conventional microdiscectomy. Another thing is that endoscopic images are 2D images, not 3D images. Vision is out of the keyhole, and then you use straight instruments. However, with microscope, it's 3D image and a keyhole, real keyhole, and you can use bayonet instruments that you are mostly familiar with microdiscectomy. So this is the system. Probably most useful part of that tube system is the table-mounted retractor system. This is a flexible arm, and the arm is connected to the table, mounted. So then you can angulate the tube and let it stay there. And the other way, with the microdiscectomy system, you can use Casper retractor or some other small retractors, but you cannot avoid the muscles interference with your vision all the time, especially in very obese patients. I must tell you that in obese patients, tube-guided system works very well, and then you are quite happy with that. So after insertion of the tube, then you can either use endoscope or microscope. There are introducers, instruments, optic parts, and the monitor. Instrument set is very similar to the conventional instruments, but if they are non-glaring type or black ceramic coated instruments, then you can be more happy with that. Otherwise, glaring is a problem. after introducers, you place a tube, and then this is the retractor system I have for. In endoscope is 3 millimeter diameter with a 25-degree angled image you can get. And the surgeon stays on the side of the pathology. If the disc herniation is on the left, you stay on the left. And the fluoroscopic image and the video monitor is on the other side. So then the surgeon looks at the fluoro image and the video at the same time. This is the setup I have used. First, a guide wire is placed, and then sequential dilators are placed. And if it is an easy level, you can use 14 or 16 millimeter diameter tube. So after insertion of the tube, you mount it to the flexible arm and then to the table. And after endoscope insertion, you can continue to the surgery. Another disadvantage of that type of endoscope is that it can get blurred your vision with bleeding. So then if it bleeds a lot, since it is not a water irrigating system, then you must take the endoscope out, clean the tip of the endoscope, and place it again. This is first a key wire, then small incision, then dilators, then the tube. This is what we see afterwards, and you can. This is the lamina, and then this is the ligamentum flavum. After looking down the ligamentum flavum, you remove some part of it, and then see the dura epidural fat, and then see the root. As usual, you make it in the normal microdiscectomy surgery. One advantage is that if you wish, you can look at two levels with one incision only by angulating your tube. So one link of tubular retractor is an advantage of the system. This is set up actually on the other side, the monitor and also the C-arm fluoro monitor. Yes. And at the end, you remove the tube, and you can see at that point soft tissues reapproximate when you remove the tubular retractor. In the market, there are metric system from Medtronic. From stores, there is EasyGo and Destando system. There are also some other companies who are producing those tube systems. I will show you one case, 55 years old male, L4-5 extruded disc herniation, downward migrated, you can see it here. And this is the short video. The good thing is that your learning time is shorter. Your adaptation to this system is shorter because you use the similar instruments you used to use in microdiscectomy. This is the herniated disc. And you can control the bleeding, use the hooks to look at the area if there is any hidden part, and place a sponge and then finish surgery and remove the tube. Yes, during removal of the tube, the muscles are reapproximating. This is almost 1.5 centimeter incision. Yes. For far lateral lumbar disc herniation, you can use the similar system. Actually, transforaminal full endoscopic system are also useful for far lateral disc herniations. But you can make it with this from 4 to 5 centimeters out of the midline incision. This is typical case of far lateral disc herniation at 3-4 level. I can show you the video. This is the some muscles are on the intertransverse ligament. After opening the intertransverse ligament, you can see the fat tissue, and after retracting the fat, you will see the nerve root. This is traversing nerve root. After retraction of the nerve root, you can see the protrusion. I have done a incision of the ligaments here, and this is the nerve root. And
I saw Turkey videos on
yes, this is the larger fragment. We removed the extraforaminal disc. I always irrigate the level and remove the tube. I have mentioned something about transforaminal endoscopy. If you look at the indications, probably 40% of the whole disc herniation can be inside that spectrum, transforaminal endoscopy. L5S1 is quite difficult. You cannot, because of the iliac crest, you cannot enter there easily. Also, some migrated fragments, migration of caudal or cranial levels cannot be done easily. But interlaminar endoscopy has more larger indications. Probably interlaminar endoscopy with full endoscopic system have been introduced by Dr. Ruten from Germany. Although there are some surgeons using it, but there is a steep learning time for that. And I have seen reports mentioning too many dural lacerations or sometimes nerve root lacerations with interlaminar endoscopy using water irrigated systems. I want to tell something about lumbar spine stenosis. In the past, we have done many total laminectomies. Then we switched to fenestrations. What was the aim for that? Because we didn't want to spoil all the interspinous ligaments and the laminar parts, so not to cause a iatrogenic instability to the spine. These are some direct X-rays AP with fenestrations. You can see fenestrations, 3 levels. Then the time has come, the new trend is that to make a unilateral approach and bilateral decompressions. This may also be done by microdiscectomy techniques. However, the tube-guided surgery facilitates that approach too much. First, you start with the tube in straight form. You then make ipsilateral decompression. Then you can angulate your tube and see the other side and then remove the or decompress the other side of the canal. Actually, this is one of my cases, unilateral position, bilateral decompression for 2 levels, 3, 4, and 4, 5. This is before surgery and this is after surgery, the below two films. Even for 4 levels, you can make it. This is a 78 years old male with numbness of both legs for 10 years and 100 meters neurogenic claudication, no neurology, 1, 2, 2, 3, 3, 4, and 4, 5 levels. And this is after surgery. You can see small fluid collections on one side only. And these are all because of decompression, you can see. And this is before surgery and this is after surgery, 4 levels. And these are the incisions, and these are after 1 month follow-up of the patient. He was very happy with that. And the whole total bleeding was about 100 milliliters. So, as mentioned before, Rutan has evolved that instead of tube-guided surgery, probably it is more minimally invasive, interlaminar endoscopy, but the learning curve is quite steep. You must work on it more than tube-guided surgery. And these are some pictures from Rutan's surgery. And you can get trouble because by turning the tube, you provide a retraction of the nerve root and the dura. In that instance, you can injure the dura or nerve root. These are some steps of that surgery. Another thing, if there is some stenosis, with this technique, there are options to drill the bone, but it's very time consuming, and then it's not that much easy as it is in tube-guided surgery. So stenosis drilling is harder, steep learning curve, baseline instruments are expensive. I will just give some small slides, one or two slides, for when to make a decompression only or decompression plus fusion. Our decision should be affected more with clinical symptoms than radiology. No good correlation between radiology and symptoms, unfortunately. And if there is some back pain, this is very important, I believe. If there is significant radiologic instability with back pain, then it's good to make to add some fusion. But if even with back pain, if there is no instability, facet injection, sacroiliac joint injection, brace and exercises can be tried. However, if there is no back pain, even there is some radiologic instability, even if there is, so decompression alone is a good option. Yes, these are my conclusions for that. And I want to tell something about cervical microendoscopic discectomy. I do it only for the posterior microforaminotomies, not in anterior surgery, although there are some surgeons who are doing also even under local anesthesia, anterior cervical microdiscectomy or anterior cervical endoscopic discectomy, sorry. These are some steps, similar things, but in the cervical spine, the fascia is very thick. It's better to cut it with a scalpel, with a knife, before placing your introducers. Otherwise, you can enter inside the lamina and then it will be a catastrophe. The disc herniation is mostly under the axilla of the root. So you just drill a middle part of the facet and a very small lamina, or you can even not touch any lamina. It is possible. This here is a view. This is the dura. This is the root, and here is the herniation. This is the disc herniation. Yes. This is one case. It's typical lateral disc herniation, and I think this one or no, this. Sorry, but I couldn't find it. I couldn't show you the video. Sorry. This is post-op films, after surgery films. This is the root. These are sponges. Sometimes more bleeding you can expect here. Conclusions: a safe, quick, and easy technique. Patient positioning is important. Mayfield head holder, slight head flexion, posterior keyhole laminectomy and foraminectomy is okay. In 2015, I have collected my series with 144 patients. Complication was in 2 cases dural laceration. In cervical posterior disc, there was no laceration or no root injury. And I haven't seen any single case of infection after such surgeries. Somebody says that with minimally invasive techniques, infection rate is quite lower than open surgery. There are good series telling this, but however, the evidence level is 3, not 2 or 1. Advantages are ambulatory surgery, short hospital stay, less tissue damage, no suprarestal dissection, and small incisions. But there is one fact I must tell you, that it's not superior to the microdiscectomy in terms of clinical results. Hospital stay and return to work were found shorter. Infection rate is less.
Hello.
In conclusion, I think tube-guided discectomy applied in all forms of herniation and spinal stenosis. Small modification of conventional instruments are the basic advantages of that technique. Baseline equipments are inexpensive, may be applied with endoscope or microscope. It is your choice, and learning time is shorter. Thank you for listening to me. We have to move our meeting in October 1 to 3, 2020 to next year, unfortunately, because of the COVID infection. But we will make a spine committee meeting in March 2021. However, we didn't decide the exact dates yet. Thank you for listening to me, and you can find all the webinars of WFN Spine Committee on our website. The website is this. Thank you for listening.
Thank you, Mehmet. It was really nice and informative overview of the options that we have in decompressive spinal surgery. I don't know if we do have time for some questions.
Maybe we can have a discussion by the end of the webinar. What do you think?
Well, excellent. Then, so
what do you think?
Maybe proceed then with the, maybe we'll leave it at the end and proceed with the next speaker.
Thank you, Dr. Zee, for this very interesting talk about microendoscopic decompression of cervical and lumbar spine. Now we will move to the second part of this webinar, and we will have the honor to present our friend Dr. Sobhi Wisa. Dr. Sobhi Wisa is a neurosurgeon, graduated specialized in neurosurgery in 1999 from Medical School of Tunisia. and he occupied many positions in Tunisia. And since 2006, he was consultant neurosurgeon in Tunisia, and since 2010, he was consultant neurosurgeon in Saudi Arabia, accredited by Saudi Council for Healthcare Specialties. Then he got the position of international observer in Cleveland Clinic, United States. And from 2010 to 2019, 2012 to 2019, he was a senior consultant neurosurgeon at Tunisia Ministry of Health. And his current position is consultant neurosurgeon at King Fahd Armed Forces Hospital, Ministry of Defense in Jeddah. His main interest is in spine surgery, image-guided neurosurgery, neuro-oncology, traumatic brain and spine injury, vascular neurosurgery, peripheral nerve surgery, and pediatric neurosurgery. And he is author of more than 100 presentations in local and international scientific meetings, and author of papers published in peer-reviewed journals and 2 chapters books. He is co-founder and former deputy of the Tunisian Spine Study Group, and co-founder and member of the board of directors of the Arab Pediatric Neurosurgical Society, former deputy of the Tunisian Society of Neurosurgery, member of the board director of the Middle East Spine Society, and he is representative of Tunisia, member of the World Spine Column Society, and member of the European Association of Neurosurgical Society. He is also many diploma and other skills. He is holder of MBA in healthcare economy from Dauphine University, Paris, and he got fellowship of the International Society of Quality Accreditation from the UK, and specialized master degree in medical repair of health damage medical school of Tunis. So his academic and scientific activities mainly. He was a member of the academic board of the Medical School of Tunis and Nursing School at Tunis, and he is a member of the Arab Pediatric Neurosurgery Society and co-founder and member of this society, and many other scientific societies. So please, Dr. Wissa, could you please introduce the second speaker? Thank you for your participation to this webinar, and could you please present the second speaker? So go ahead.
Okay. Thank you for Moroccan Society of Neurosurgery, for my friend Naji Abedi and Fahd. Thank you for inviting me, for contributing to this nice webinar. And I am very delighted to present Professor Kiki Turel, for those who unfortunately still does not know him. He is from Mumbai, India. He's currently working as emeritus of the Department of Neurosurgery of Bombay Hospital Institute of Medical Sciences. And Professor Turel has 50 years experience in neurosurgery and had big achievement in all fields of neurosurgery, in brain, peripheral nerves, and spine surgery. Listing his very long list of qualification awards, honor, and prize will take too much time for us, and we don't have too much time for this. So we can say that he's FRCS, FACS, FICS, and he's also very active in neurosurgical and neurosciences societies and association. He's currently chairman of the WFNS Committee of Complication in Neurosurgery, and he's past president of Neurological Society of India, of Bombay Neurosciences Institute, and Asia Oceania Skull-Base Society. Today, Professor Turel will present us microsurgical internal decompression of lumbar spine stenosis. So welcome, Professor Turel. Thank you for coming, attending, and enjoy for attendees. Thank you.
Yes, thank you. Namaste. Thank you very much, Dr. Nazia. Thank you very much, Professor Sobi, for this generous introduction. And I must say, Namaste. It is a traditional Indian way of greeting, which relieves the stress and relieves the anxiety. But today it has become fashionable and very necessary in COVID times to greet people like this, so that you have no touch technique. Let me talk to you about my very favorite trademark operation of microsurgical internal decompression of spinal stenosis. Which I call as MIDSS. And this is a operation which I do in most patients of lumbar stenosis. We can define canal stenosis. What happened? Yeah. Yes. Okay. Thank you. So lumbar canal stenosis may be congenital, like an idiopathic or achondroplasia, as you see in this gentleman, but it is mostly acquired, again degenerative, which may sometimes be combined with congenital, spondylotic or listhetic, and quite often iatrogenic, post-laminectomy, post-fusion, post-traumatic, and occasionally with metabolic diseases. The morphological factors which produce stenosis are concerned with the lamina by virtue of its shape and thickness and angulation, especially two facets almost joining together with almost no lamina in between. You may also have facetal hypertrophy, where the facets are thickened, but apart from that, they are hypertrophic, as in arthritis. And to add to all this, because of some degree of instability, you have ligamentum thickening, and this yellow ligament hypertrophy narrows the canal even further. You can have combination of one or more of these factors, and it can get worse if you have a disc herniation to the pre-existing stenosis, by which means you precipitate severe neurological events and also pain, which are not remedied by rest and analgesics, unlike in a straightforward disc prolapse. So you have a normal canal on your left-hand side, and you see stenotic spinal canal. So you have a central stenosis, you may have lateral stenosis on the sides, and you may have foraminal stenosis towards the nerve root exit zone. So we can have variety of stenotic factors. And here you see how a nerve root eases out very easily from the spinal canal with a normal facet joint. But if you have a hypertrophic facet, then this is the way it gets overstretched. Clinically, the patients present with backache. They may have sciatic pain, depending on the dermatome, which is most narrowed and most severely compressed. They may have paresthesia and leg cramps. Neurogenic claudication is the hallmark of spinal stenosis, where exercise, pain, rest, relief cycle. Very rarely, you may have Corda-Equina syndrome as well. And this happens particularly when you have stenosis, along with that, a large disc prolapse. There are some uncommon or less recognized symptoms, such as spinal freeze phenomena, where you have unprovoked severe paraspinal spasm. The patient almost gets into a kind of a frozen situation and is unable to even move at all or change his posture sometimes for several hours of the day. They may also have cramps in the calves, and this happens particularly disturbing during sleep. And patients are unable to sleep. They keep walking at night because of these very severe night cramps. Some people are ashamed to talk about diminished libido, but if you ask them very directly and privately, they may agree to confess that, yes, their sexual ability also has much reduced. So lumbar canal stenosis classically has more symptoms and less signs. For example, if they have no disc prolapse at all, they may have intact neurology and an unrestricted SLR. Yet conversely, some of the patients are prone to severe neurodeficit compared to those suffering from pure disc prolapse. So canal stenosis can be diagnosed when I was a young neurosurgeon, beginning my career, even before CT and MRIs, we used to diagnose them purely by lumbosacral spine X-rays. And I've described these signs. There was a reduced interlaminar trefoil. You can have an oblique lie of these facet joints, and you may have bulbous zygapophyseal. You can see almost in one patient all the three signs of lumbar stenosis on plain X-rays. And this can be a ready diagnosis. So I described this oblique lie sign something like 30 years ago. Plainly on plain X-rays, you can see how the facet joint line is obliquely placed, and you can then also see its appearance on the MRI. So the investigation of choice, of course, today is MRI, because it detects stenosis at various levels and also tells you the various causes of stenosis at each of these levels, whether it's apophyseal joint hypertrophy or ligament flavum or disc prolapse or a mixture of these. We also sometimes conduct an EMG nerve conduction study, especially it is absolutely necessary in diabetic patients. But even when patients have gross symptoms but have less pronounced imaging signs, that means if there's a mismatch between clinical and radiological findings, EMG nerve conduction can be very helpful. Occasionally, I still perform myelography much less often than before. And this is particularly when there is a post-operative patient complains of stenosis and the MRI gives you a very confusing picture. You are unable to see. So then we have this, what is this line? The myelogram gives you a dynamic study of flow. It identifies extent of block at various levels. It shows impingement of the root sleeve. And then when coupled with clinical findings, it helps to localize the increment levels, which the MRI may fail to do so. And now on the left-hand side, you see particularly after a spinal fusion, this patient has got severe pain and a neurological deficit as well. And MRI will give you a very confusing picture. Here I am injecting the dye and you can see a complete blockage at L4-5, total extradural block. I don't know how this oblique line has come. This oblique line sign of mine has come on my screen now. Okay, CT myelo, therefore, is now regarded as a gold standard of diagnosis in these patients who are unrelieved by surgery. We have heard someone earlier, Dr. Zileli also spoke about multi-level stenosis. Now, when you see multiple level, on the left-hand side, you have a plain X-ray on the same patient's MRI. It shows multiple levels of stenosis. Now, you may not, on the right-hand side, there's another patient with multi-level stenosis. Now, the point is, are you going to decompress each of these levels, or you're only going to operate on the patient whose level is symptomatic? So this is a very important clinical decision, because very often you find patients presenting with signs, with radiological signs at every level, L1 to L5. Are you going to operate on all of them, or only one which is clinically symbolic? So a multi-level stenosis is actually an MRI diagnosis and not a very clear entity. And therefore you would treat by decompressing the relevant clinical level. That means I would say operate on the patient, not on the MRI. The next point in canal stenosis is standard epidural veins. And neurogenic claudication in a less significant canal stenosis may be occurring because of epidural veins, and they distend, they occupy space and cause pressure. And these veins can sometimes form a constricting band as they cross over the nerve roots, practically straddling them, entrapping them. So these veins are quite significant when you open the spinal canal. And I have a hypothesis that when a person is active, there is an increased arterial blood flow, but venous return is impeded by spinal canal stenosing factors, causing venous engorgement, and this causes consequent pressure on nerve roots, and that causes pain during walking, which is exactly what we call as neurogenic claudication, because of venous engorgement. When a person takes rest, the venous engorgement disappears, there is disengorgement as I call it, and the patient once again becomes relieved and he starts walking. So this is my hypothesis of venous distension causing neurogenic claudication. But even during sleep, these patients can have, as I earlier on told you, that you can have night cramps. And this is because of increased carbon dioxide in sleep at night. This causes venous distension, again compression of nerve roots, the same way as I told you, severe and painful night cramps. Then these patients actually tie tight bands around their legs. They try to get them pressed by somebody, by their spouse or anybody else at home, and this, or otherwise they just get out of bed and start walking in the middle of the night in order to distract their attention or get relief. So claudication may be due to severe canal stenosis per se, or it may be moderate or severe canal stenosis with disc herniation. And sometimes it can be these factors along with distended epidural veins. It can be moderate stenosis or mild stenosis, but very significant distended variants. So I will talk to you about this procedure of microsurgical internal decompression of spinal stenosis, which is an ideal procedure which treats spinal stenosis by decompressing chorda equina and nerve roots, and may obviate the need of an instrumentation in all cases, including grade 1 spondylolisthesis, and still maintaining architecture of the spine. The indication is lumbar stenosis and even degenerative spondylolisthesis grade 1. The principle is interlaminar internal decompression, what we call as the fenestration, or widening the narrow spinal canal and the recesses without doing laminectomy, without disturbing the bony architecture, or without disturbing the interspinous ligaments and supports of the lumbar spine. So it's a virtually minimally invasive, non-traumatic procedure. So if you have a person who is so stenotic that he practically do not see his laminae, now why would you do a laminectomy in a patient like this? You remove his spinous process, you remove the interspinous ligaments, and there is very little lamina to remove to get a wide decompression. In this kind of a patient who has got a ligament hypertrophy and lateral stenosis, you would rather do a interlaminar decompression like this and spare the laminae and spare the spinous process and spare the interspinous ligaments as well. The procedure of this MIDS is done by the regular position on Wilson frame, exposure, widening the interlaminar space by using variety of drills, scoops, curettes, and punches. You may have to do mesial facetectomy sometimes of the superior facet of the inferior lamina, and then you enter through this core, through this fenestration, you core out the canal from within, like making a tunnel, widening, making a tunnel through a mountain, cutting the tethering bands which are holding on to the nerve roots, coagulating and disconnecting the distended veins which are anchoring these roots. And then, of course, if you have disc prolapse as well, then you do a discectomy. So this is the position of this patient on a Wilson frame. You may make a unilateral exposure or bilateral exposure, but it's just a 1 to 1.5 inch incision, not longer than that. You just need to expose that particular spot which is causing stenosis. And here you see two spinous processes opened by this 1.25 inch incision. Then you would use steel burr at the beginning once you expose the laminae, and you then use the diamond burr later. So now you see my arrow showing you increasing the interlaminar fenestration by doing the superior border of the inferior lamina first. I try to do that because the nerve root is going to escape from there. So I like to see the nerve root which is going to leave the spinal canal first by drilling the superior edge of the inferior lamina. And then I drill the superior border, the inferior border of the superior lamina, and widen the fenestration. Thereby I can see the axilla of the nerve root, and if there's a disc prolapse, I can get to the disc space also from the same way. So this is my sequence of drilling, starting with the steel burr and then ending up with the diamond burr. This is exactly contrary to a standard disc operation, which at most, normally in a standard disc operation, you don't even require to drill. But if there's a little narrowing, then you may drill the inferior border of the superior lamina, because that is where the disc space is located, and that is where the disc hernia occurs. So the surgical technique I'm going to show you by my operative procedure: microsurgical internal decompression of spinal stenosis. What is this again? That will be.
Start automatically. Started.
No. Okay, so I'm going to show you a couple of representative cases. This is a 52-year-old male, low back pain radiating to both lower limbs for 6 years, and calf muscle cramps. He's in such agony. You rarely see patients coming in such an agony, but all bent over, because by bending they open the spinal canal slightly more. He requires support. His plain X-rays shows this typical oblique lie sign, which I described, and his MRI shows a very hypertrophic facet joint. And here I am putting in prone, exposing L4, L5 laminae, and the inset shows exactly what I am going to drill. The upper border initially of L5 lamina, stenosis is between 4 and 5. So as I am drilling, and I get on to the medial part of the facet, because it's usually the upper facet, the superior facet of the lower lamina, which impinges, which narrows the spinal canal from within. And after doing the initial work with steel burr, I get onto a diamond burr, because as you go closer to the dura, you would like to avoid any kind of trauma. And usually steel burr in that case is safer. And as soon as you've done that, you come down to ligament flavum, start widening the bone, start opening the ligament, thickening ligament by grasping it with the alligator forceps, and then cutting it with an 11-blade scalpel. And gradually, as the thickened ligaments come out, the spinal canal gets widened, the fenestration gets wider, and you get a big hole to visualize to enter the spinal canal. Now, I'm using scoops to core out from inside. That's why I call it internal decompression. I also use punches, initially starting with a small punch of 1 mm, 2 mm, and then gradually reducing, you may go on to 3 mm. I put my guide, and the guide showed that I was still getting blocked. So I use a steel bar again, and I'm now working on the inner aspect of the lamina, widening it further. And now my root guide is passing very easily, so I can follow the nerve root comfortably. Now here comes the medial facet. I can use a very thin micro chisel and just take out 1 millimeter or 2 of the medial facet by hammering it out. And here you can see a substantial part of the facet joint being drilled away. And then with a hook, I gently ease it out, use a grasping forceps like an alligator, take it out. And then you have always, when you decompress, the spinal veins bleed. And that is in fact a sign of good decompression. And now you have a good fenestrine on the left side and the right side. And then this is the size of the incision. And this is decompression without laminectomy. Initial trifold is now made into an H-shaped. And you can see the patient 2 days after surgery. On the second day, you saw how he was walking. He had to be helped to come inside, even to walk in the operating room. And now here you are seeing him walking very freely. And he still can't believe that he has no pain. And he's climbing his stairs and ready to go home in a second or third day. And you can see, of course, he's very careful and very cautious, but he's independent and completely free of pain. His post-operative scan shows this typical large H-shaped defect after decompressive fenestration at L4, L5, MIDSS. In some patients earlier on, we have done fenestrations at multiple levels, but I don't believe you require decompression at so many levels, generally speaking, because root pain comes usually from one root, and you must have clinical sense to identify which one it is, and then just decompress that particular root. Here is a patient who has this disc, lumbar spinal stenosis with a disc prolapse. Oh, what happened again? It comes on its own. Oh. So this patient has got a left-sided disc hernia along with stenosis. I follow the same regime of drilling the facet upper border of the lower lamina and then the lower border of the upper lamina, and drill out starting with a steel burr, and irrigation, of course, at all times, because you need to keep the area cool. Otherwise, the dura or the nerve roots can get thermal injury. Mind you, steel burr is not as thermal producing as a steel burr, as a diamond burr. Diamond burr is very thermogenic, so you have to give good amount of irrigation, but it is safer. Even if you land on the dura, it is not likely to cut the dura. So as you approach the spinal canal, you change over from the steel burr to the diamond burr, or you can work entirely with the diamond from the very beginning. And then as you enter the canal, you take the ligament flavum and start cutting it off. Almost the same thing as I showed you a little earlier. And then usually ligament flavum is easy to just pull out. It does not produce any trauma to the dura, even though it may appear adherent. You can easily pull it out, but it's safer to grasp with one forceps and then cut with the 11 blade flush with the bone. So you cut it nice and clean and fairly wide. Now you can see me passing my root guide to make sure that I have decompressed sufficiently above and below. And then you have, in this particular patient, because there is a disc hernia, we have already exposed up to the axilla. So you're also exposing these inferior lamina, inferior border of the superior lamina, and then you go on to the identifying the, so you identify the disc material and do a microdiscectomy like you normally do. So I'm not going to show you the process of microdiscectomy. So I go on to the next case. Here we have lumbar canal stenosis with engorged veins I spoke to you about, and there are big venous bands. And so I've already done the decompression, bony decompression, but you see very large veins. These are not large veins because of bad positioning. Sometimes you get very bad venous engorgement if you have not kept the abdomen free. And that's a prerequisite for any lumbar spine surgery. But here, these are distended veins which are causing severe root compression. And they may be in isolation or they may be in addition to bony and ligamental stenosis. But I already explained to you my hypothesis of how engorged veins can produce embarrassment of the nerve roots. And then sometimes if they are still very engorged, you may coagulate and cut them. But usually I leave them behind. I only coagulate and cut those veins which are strapping over or straddling over the nerve roots as they exit. We also now do, from a unilateral exposure, I can do a bilateral decompression. I don't have to do the opposite side. And a case, an example here is an 82-year-old gentleman with neurogenic claudication and reduced SLR and a disc collapse both. So here we have an L4-5 interlaminar exposure. I'm clearing the soft tissues, taking away all these strands, arachnoid strands, the fat, decompressing again by internal decompression by using scoops to widen the canal from within. And after I get there is almost no interlaminar space at this moment. Because of the aging, there's almost a telescoping of one lamina into the other, or one facet joint into the other. So here, this really requires a sufficient bony decompression to widen the interlaminar space. Once the interlaminar space is done, the fenestra is widened, then you go on widening as much as it is necessary to. I usually use the diamond burr to also drill the inner part of the lamina, steering clear of the dura. And it's always safe when you are drilling to keep your ligament flavum intact. Your ligament flavum should count last after all your drilling work is over. Otherwise, you expose the dural tube to the force of drilling or to the hazards of drilling. So at the end, you are just using scoops to decompress. And there are some engorged veins as well over here. And now, after drilling sufficiently, I work under the spinous process. I do not, only that part of the interspinous ligament, which is roofing over the dura, is cut. And then you go on to the opposite side and decompress the other side. So it's a bilateral decompression from this side. Now, there are some pitfalls and complications, like identification of correct level. It's a very simple explanation. You must, some simple mistakes sometimes people make, especially with sacralized L5 or with a lumbarized S1. And you need to confirm that. For example, on your left-hand side, you see the MRI, which shows a sagittal T2 weighted image in a lumbarized S1 vertebra. And the plain X-ray also shows the same thing, lumbarization of L5. That means S1 becomes L5. On the other hand, you can have sacralization. So you see the last vertebra as L4, and there is no interspace between L5 and S1. So the last space is L4-5. So you must be very careful in nomenclature, in your semantics as to what is the, and this you can compare with the MRI and be very careful when you're doing your fluoroscopy. The other complications are damage to dura and neural elements during drilling, chiseling, and punching. And this particularly happens when a person is very osteoporotic, elderly people, women particularly. So they can, and also you can damage the spinous process, and you can actually crack the lamina whilst you're using the scoops to scoop out the bone. The another complication or pitfall is sometimes you do inadequate decompression. On the table, it appears like everything is very nicely done. So my trick is that after you feel you've done sufficient decompression, you flatten the Wilson frame and make the patient flat, because you're operating in a relatively kyphotic position. So you make the patient flat, almost lordotic, not lordotic, almost lordotic. And then you check whether you still have enough space for the spinal canal and enough space for the root to leave the spinal canal. So that will ensure that you've done adequate decompression. So I would conclude by saying MIDSS is a minimally invasive surgical technique for lumbar canal stenosis, achieving internal decompression or widening of the spinal canal without disturbing the bony architecture or the interspinous ligamentous supports of the lumbar spine. I will just end my presentation by telling you something about my international conference that we have been having on complications in neurosurgery. And in fact, Mehmet Zilali has been our strong supporter. He has been there for both my meetings in 2017 and 2019. As you know, complications are an unfortunate part of any surgery, which makes treatment worse than the disease and the suffering of the patient, of the family, of the neurosurgeon, and even our specialty of neurosurgery. We always prefer prevention is better than cure. We say anticipation, prevention is more important to avoid complications. During these meetings, we also consider ethical considerations, philosophical aspects, our moral obligations and probity, and legal implications of complications. So in these meetings, we have very frank discussion amongst ourselves on pitfalls of management. We talk about not how I would do it, but I would say how I wish I had not done it that way, or how I wish I had done it differently. Open forum of failures and how we learn from it. And we know we all have complications. No neurosurgeon can say he doesn't have complications. Either he is lying or he is not operating. So failure is a defeat only if you don't learn from it. We had this announcement in 2017, and then we had a second equally successful or more successful conference in 2019, where all leading international and society meetings had contributed and patronized it. And then we are now hoping to have our third ICCN. I don't know if the COVID virus will allow us to meet physically. Otherwise, we will have a virtual meeting in March. The dates are already fixed, 5, 6, and 7. And you can see on the left-hand side all the red flags of complications. Now we are conducting our virtual webinars on complications by VCME, as we call it. And every 2 months, on the last Friday of the month, we are having a webinar on complications. We already had a formal launch by our world president, Franco Sabadai, and my mentor, Majid Sami. And then we had 2 successful webinars, one on skull base and the last one on vascular complications in neurosurgery. And we had active participation from at least 11 participants on each of these. And these webinars, which were scheduled for 3 hours, went on to almost 5 to 5.5 hours because of extensive discussion, very aggressive discussion. And the next one is going to be on CSF leakage, and that will be on the 30th of October, the last Friday of this month. Today is the 1st of October, and the flyers have already gone out. You will find this on your mailbox today onwards. So please come and actively participate in this. Our first book on complications in neurosurgery is now almost ready for distribution. It is being published by Acta Neurochirurgica, and it is being co-authored myself with Mikhail Chernov and Rishikesh Sarkar. Thank you very much once again, Dhanyavad, for your attention. Thank you.
Thank you. Professor Sabri, you will say
Yes, sir.
some words before.
What?
would you
Excuse
say
me?
some words before starting the next talk?
No, thank you. Thank you so much for Professor Turel for his brilliant lecture. And we can pass to the next speaker. Yes.
Okay, so
And the question are for the last of the at the end of the
Yes,
session, as said Dr. Fat.
Okay. So we will now next speaker is I will have the honor to present my colleague Professor Said Hilmani. Professor Said Hilmani is a neurosurgeon in the Department of Neurosurgery in the University Hospital Center in north of Casablanca and professor of the University at the University Hassan II in Casablanca. He is a member of Medical School Council and a member of the Pedagogic and Academic Council of the Medical School of Casablanca. He is currently the president of the Moroccan Spine and Spinal Cord Society and Secretary General of Arab Spine Society of Neurosurgery, and also the former Secretary General of the Moroccan Spine and Spinal Cord Society. He is organizer of or faculty of several national and international workshops on surgery and organizer of faculty of several national and international meetings. He has more than 30 scientific publications in peer journals, and he participates with two book chapters in medulloblastoma and brain metastasis, and he's reviewer at the Surgical Neurology International and Biomed Central Infection. So please, Professor Hilmani will talk about the spinal tumors between conservative and surgical management. Please, Professor Hilmani.
Thank you. Thank you, Professor Khadar, for this kind. You show my screen, please.
Yes.
Thank you, Professor Khadar, for this kind introduction. I would like to thank Professor Abadi for this kind invitation and for all the effort which she makes to improve neurosurgery, spine surgery, and all the neurosurgical disease in the Arabic world. Thanks also to all the organizers. I would like to thank you also for giving me this opportunity to share with you our experience in Casablanca about primary spinal tumor management. Before starting this surgical procedure, let me talk about some backgrounds. As you know, primary spinal tumor comprising the largest and heterogeneous group, either malignant and benign tumor. Certainly, primary spinal tumor is less common than metastasis. It represents less than 5% of all bone cancer. In USA, there are among 2,000 new cases each year. Surgery is the mainstay management of primary spinal tumor, followed by oncological treatments. But several brain tumor, several spinal tumor, are resistant, especially malignant, but also some aggressive primary spinal tumor. So making surgery the treatment of choice, which must balance between local control to avoid recurrences and the risk of recuperating the patient and health-related quality of life. In this one of the best or important epidemiological study of about primary spinal tumor, which we find that benign tumor is more common than malignant tumor, and the benign tumor is more located in the cervical spine area, followed by thoracic, lumbar, and sacrum. But malignant tumor are more located in thoracic spine and sacrum, in cervical spine and lumbar spine. In the same study, we find this heterogeneous group in the benign and the malignant tumor. In the benign tumor, the hemangioma and giant cell tumor and some others benign tumor are frequently found in this group. But chordoma and lymphoma and myeloma or plasmacytoma are the most frequent disease in malignant spinal, primary spinal tumor. When we talk about classification, there are two important clinical features according to histological data. It concerns age and anatomical location. Most of the primary spinal tumor have occurred among several cells from the bone, cartilage, lymphoproliferative cell, notochord origin, or others cell. So either in benign and malignant tumor. First, let me talk about some principle and terminology. One of the pioneers in the bone tumor surgery is Dr. William Fisher Hennigan, which born in 1926 in USA, is the pioneer of tumor staging, certainly in the lamp tumor, but this can be used in the spinal canal. I think that when we want to manage spinal or primary spinal tumor, we can have in our mind three steps or three stages: before surgery, during surgery, and after surgery. Before surgery, before surgery, we must have a classification of tumor staging, which divided into five groups according to their location, to their potential growing and their extension from intracompartmental to extracompartmental. During surgery, we must have some skills, certainly, but we talk about intralesional, marginal margin resection, wide resection, or radical resection. After surgery, the piecemeal or pathological resection of this histological study, according to the surrounding health tissue surrounding the tumor, we can have some criteria about if the tumor have resected intralesionally, marginal margin, wide, or on block resection with healthy tissue surrounding the tumor. But there is one difficulty when the dura was involved. So benign tumor are divided in three stages. Stage one, it's about latent tumor. The tumor is in the bone with well capsula and no or low growing, like hemangioma, some hemangioma certainly. Stage two, it concerns the active tumor. This tumor have a thin capsula with slow growing like osteoma, osteoma, or aneurysmal bone cyst. The third stage is concerned the aggressive tumor. This tumor is a high growing. This tumor is characterized by a high grade and a high growing with a very thin capsula and extended to the surrounding the area of the dura or into the canal. So osteoid, the first benign tumor, osteoma occur occur in the second decade and located especially in the posterior element or posterior arc, which must be resected en bloc or with a wide resection with safe or healthy, safe surrounding tumor and associated to fusion. Osteoblastoma is the second benign spinal tumor. It's occur into the second or third decade. It's occur also on the posterior element and sometimes is associated with scoliosis, which must be corrected. It's not very necessary to correct the scoliosis, but because in some cases the scoliosis is very important and is associated with pain scoliosis in difference with idiopathic scoliosis. Osteochondroma, it's the benign tumor, but aggressive benign tumor. It's occurred in the third decade and located exclusively in the posterior or the middle area of the vertebra and must be resected widely or on block resection, as we see in this picture with a good recovery in this patient who was with paraplegia. Giant cell tumor is aggressive, in some cases aggressive benign tumors located on the anterior body and needs a large or wide resection with fusion, especially in the cervical spine. Others benign tumor as hemangioma or eosinophilic granuloma or Langerhans cell histiocytosis occur in the vertebral body, especially, and are characterized by its CT scan or an MRI. Aneurysmal bone cyst is also a benign tumor, but in some cases it's very aggressive and its management needs good skills. Best management needs wide or on block resection and needs embolization before surgery. In summary, benign tumor in stage 1, we can wait and see when the tumor was asymptomatic or with a very, very low growing without symptom. In stage 2, the tumor is with slow growing, needs intralesional or on block resection in some cases with very, very low recurrence. But in aggressive stage, tumor is very aggressive. It needs a radical treatment, but in some cases it's difficult to do this radical treatment. In other hands, malignant tumor is also divided in 2 stages, but with 4-5 subtypes. Stage 1, it concerns the low-grade, low-growing but malignant tumor according to intracompartmental or extracompartmental. It concerns stage 1A or 1B. The second stage, it concerns the high grade with rapid growing, and also it's divided into 2A or 2B according to intra or extra compartmental extension. But in stage 3, it's a very, very high grade with regional or distant metastasis. This needs especially a palliative treatment, as we show later. This classification is used by Tomita, especially in the metastasis, but I think, in my opinion, we can use it especially in the sagittal plane to show the extension in this plane to the surrounding spinal tumor, the vertebra below or the vertebra above. This group of malignant tumor osteosarcoma, it's a very aggressive tumor and occurs into the anterior canal, anterior vertebral, and growing to and with extension to posterior arc, and needs a wide or en bloc resection to conceal with conservation of the nerve and the vertebral artery, with improvements of clinical signs, as we should see at this patient. Usually we need fusion and immobilization and fixation, occipitocervical fixation or others fusion. Myeloma or plasmacytoma is also one of the frequent malignant primary spinal tumor. I think that the need or block or radical resection, but in some cases we can do wide resection with cementoplasty after posterior decompression with fusion, and we can have a good recovery with a low recurrence after being added to oncological therapy. Ewing sarcoma is the tumor of pediatric tumor, but we can have it in second or third decades. The needs also this tumor need wide or en bloc resection, but in some cases we can do percutaneous or low or minimally invasive surgery after when we have post-asymptomatic with balloon or cementoplasty associated with fusion. The chordoma is one of the frequent malignant and aggressive tumor. It's occur in the middle age and are extensively affected the vertebra with extension to the posterior arc. They located especially in the sacrum, but we can have it in others location as spinal region, as we see in this patient with huge chordoma, cervical chordoma with extension on the cervical and retropharyngeal extension. This patient needs a block or wide resection with vertebral artery to avoid, we make all to avoid injury of the vertebral artery or nerve root with prosthesis and fusion, and with good local control and a good recovery, as we see in these cases. In summary about malignant tumor management, I think that in the low grade A1, 1A and 1B, they need en bloc resection. In the second stage, in 2A or 2B, we must do wide or en bloc resection, but in stage 3, we need a palliative treatment. The goal of surgery is oncological removal of the tumor, decompression of the spinal canal, the spinal cord, maintenance of the mechanical stability, relief pain, but one and the important point is improvement of health-related quality of life. It's very, very important to have in our mind when we must manage this patient. Some pioneer surgical, spinal surgical have suggested a staging system according in the axial plane because surgical procedure and making decision is very, very complex stage. And facilitating this procedure, they divided the vertebra into 12 zone, to 1 to 12, quite side order, and to 5 layers from extra compartmental to intradural involvement. This allow us how to manage and where to do and when to do the block resection or intralesional or wide resection. I think that in zone 9 and in zone 5, as in zone 4 and in zone 8, on block resection with anterior, posterior, or combined approach, it's very, very important strategy to have a good local control and avoid recurrences. Also, when the tumor is located in the center of the vertebral body, anterior approach is the adequate management for this patient. On block resection, it's not easy technique, but it's safety. It can be used safely and not. I think that it's not very easy, but we can do it in selected patient. As we see in this table, we can do it in stage 1, stage 2, but in stage 3, it's very, very difficult to do it. Then the palliative treatment is the mandatory management. According to Enigen or Boriani staging, zone 4 and zone 5, for AIDS, zone 8 and zone 9 need vertebrectomy, but others area needs intralesional or wide resection tumor. This on block resection is can be done safely, but the on block resection is very strongly recommended by many authors as which we is recommended or was recommended by our spine or the spinal oncological study group. But when we talk about quality of evidence, this technique is very low or low evidence. So this on block resection is associated with significant morbidity. This can be done for 70–30% and high mortality in some cases, even in the most experienced center. So this technique, it's not very easy, as we say in this slide, with main risk as massive intraoperative bleeding, mechanical or vascular injury, dural tear, sacrifice of nerve root or blood vessel, mechanical instability, contamination, and others complication. So between safe management and radical management, we can assess and evaluate our patient safely with staging, with classification to give the good procedure and the safe management. But when the patients are not able to be operated, palliative treatment is mandatory. As we see in this slide, the osteosarcoma or chondrosarcoma, chordoma are resistant and needs aggressive surgery, but others are sensitive tumor needs wide or intralesional resection followed by oncological therapy. In some cases of benign tumor, quasi-asymptomatic, there are some techniques which we used by several authors, the minimally invasive or percutaneous techniques as thermal ablation or radiofrequency are used for some selected patients. And finally, or in conclusion, the first surgery is the best, and the patient must be referred to reference center to have a good surgery or good management. On block resection, vertebrectomy or spondylectomy must be used even it's possible, it's feasible and safely in selective patients. But palliative management is a device in operable patient. The wait and see approach is very rarely indicated in some slowly growing tumor or asymptomatic patient. I think that this patient should be treated according to the best available evidence. And thank you for your attention.
Thank you, Professor Hinmani, for this topic focusing on the management of spine tumors. Now, may I ask the panelists, Dr. Nikolai P., Dr. Sobhi Wissa, and Professor Nizar Al-Fatimi to animate the discussion.
Discussion is
So Nikolai P., for the first topic.
Yes, so as I commented in the beginning, this was really an informative way and really a good overview of the all the options that we have for decompressing the spine. And so my question to Professor Zileli is, what is his first option of choice for lumbar decompression of all the options that he presents in his practice? What is the most what he's using and why?
Thank you, Nikolai. Currently, I'm using tube-guided surgery in all degenerative spine decompressions, in almost all of them. But if it's necessary to make a fusion, no, I don't use it.
Right. So do you see a big advantage of tube surgery versus modern retractor systems? That was my question. Because most of the modern retractors, they still can give you a very small opening, and you still can go across over the top and decompress contralateral side.
Yeah. Probably, as I mentioned in my talk, for the patient satisfaction or long-term results, there is no difference. There is no study telling that endoscopic discectomy or microendoscopic discectomy is superior to the microdiscectomy in terms of the outcomes. However, there are good studies telling that postoperative pain, postoperative analgesic usage, and return to work and hospital stays are better, somewhat improved than the others. This is all. Actually, probably we are forced by the patients to make minimally invasive surgery. This is the demand of the patients. Not
I agree with you. I agree with you. But is that, my question is, are we really doing that because patients are demanding, or we really see a real benefits of it?
But I must tell you, sometimes if the tube system, I have two tube sets in my practice. If they finish, if I have a third case, if the first one does not come from the autoclave in time, I can do with Casper retractors. But I'm not
Exactly.
very happy with the Casper retractor because the image is disturbed by inside the view entering muscles, and you cannot angulate your view easily, and especially in the fat people, very fat people, it's easier to use the tube.
May
I
I,
have a question.
may I
Yes,
ask
please.
a question, Nikolai?
Of course, please, please,
For
please.
Professor Zilili, it's about his great experience in endoscopy in this area, and he showed us. I think since 2015, he operates more than 150 by transforaminal or translaminar, 40 versus 60%. I would like to know in how many percent you still use the conventional discectomy or laminectomy, and in how many percent also it happened that you have to convert from endoscopy to the open surgery, and what your advice for the young neurosurgeon who would like to start this endoscopy. In my department, Fahd Derkawi, my collaborator, he's the coordinator of this webinar. He's currently most interested by surgery and of course minimally invasive and so on. And we started, of course, the endoscopic and surgery for her disc herniation, but it took a really very long time, and sometimes I'm behind him to tell him, please, you have to go faster, because we have three or four patients after this operation. So what's your advice for this young neurosurgeon to learn? We know that the learning curve is it's here. We need to follow many steps to shorten that. But what you'd advise for this?
Yeah. If you look at the full endoscopic system, water irrigating system, to make a transforaminal endoscopy, the learning curve is quite long, because you enter the disc from a very unusual place, cumbent triangle. So in those cases, I have talked with the very experienced surgeons. They tell after 100 cases, you are more comfortable with the transforaminal endoscopy. But I will tell you with that tube system that I have shown you, probably after 50 cases, you are okay. Did I convert any time to open surgery? No, I didn't. I don't have a single case that I have to convert it. In cases of dural laceration, you must be, however, familiar with dural stitching under the tube. If it is a large incision, then you can make the stitching. The only problem is that lowering the knot inside the target is not easy. Then your assistant must help you on that. There are even some technical reports that is addressing that issue to lower the knot to the target.
Can I have a question, please?
Yes.
Nikolai?
Yes.
So, Professor Zileli, you said one of your indication is patient request for doing this minimally invasive surgery. But my other question is, do you have criteria for selection for doing minimally invasive? And for other participants, are insurances and paying companies pushing you to practice minimally invasive regarding the cost effectiveness?
Yeah, I'm not telling you that you must always do this. Actually,
No.
I have told already the outcomes are same in the long term, but the patient comfort at the beginning is quite better than open surgeries. For instance, we can ask Dr. Keki Turel. His surgeries was not minimally invasive, I think. Do you agree with that, Keki?
Well,
I have seen your videos. You have opened the space largely. Although you have used a microscope, but using microscope in every instance does not mean it is a microdiscectomy or microdecompression. You must use the so-called Casper retractors or very special retractors. If you don't, this is an open surgery by the help of microscope.
if you're looking for an answer from me, I would say our patients are, well, maybe more hardy or tough. They tolerate the procedure reasonably well. Most of them are discharged on the second day after surgery. There is practically no back pain, and of course the sciatic pain is so significantly gone that they are in fact grateful to you because the original problem is gone. So instead of complaining, they are always appreciating, and they forget even if there is a local wound pain. And even wound infection rates are, I have not seen in reality. There is no wound infection. No wound infection.
There is a very nice study telling that wound infection in minimally invasive surgeries are 10 times less than open surgeries. The second thing, even that case with 4-level decompression, I discharged in 12 or 18 hours.
Yes.
Not the second day. In
Yes.
one day, you can discharge.
Yes.
So there are some advantages, but in the long term, it doesn't matter much. So then the advantages are not that much huge. Yes, we are forced by the patient's demands, but after a while, you can be very familiar with those techniques and you can make all your surgeries with this. Nowadays, I do no spinal stenosis, no disc herniation without a tube.
Mehmet, I will just comment on something. I was speaking with Hyung-Sung Kim from Korea recently, and I've asked him, when did you do a open discectomy last? And he said 4 years ago. We know that Kim is doing almost everything now endoscopically, and maybe what is not possible now with your experience later on with the cases becomes possible. And yeah, I agree to, I also feel sometimes that I've been driven by the demand of the patient, but I also see the advantages, and I think you're quite right. I see that the complications, the blood loss, and all that is way smaller with the minimal invasive surgery.
Right.
Sometimes I feel that I'm driven and I'm pushed by the patient, but also I see the advantages. Another thing, I think it was a very good question asked by Professor El-Abadi about what we advise young neurosurgeons when they want to start doing this minimal invasive. First, I think maybe even if in the beginning, if it's not true minimal invasive, every problem probably be possible to. The big problem can be grinded to a few small problems, and maybe you start initially applying some of the principles and then continue with develop your technique. For example, when I started doing endoscopic surgery, I first started doing my injections, and I was following the trajectory of the transforaminal surgery, with my injections, and this helped me to get my trajectories later on when I started doing endoscopic transforaminal.
One point is that in the Foley and Smith's first series, they were telling that recurrent disc herniations are not an indication for tube surgery, actually microendoscopic discectomy, because they were believing that the root injury will be much more. But then they changed that idea, and then I'm doing all the recurrences if I don't think there is any instability.
Exactly. What is not possible in the beginning, well, with your experience, it becomes possible.
Right. Yeah, there is some learning time, but it is not that much long as it is in the transforaminal discectomy.
That's true.
There is a question in the chat by Mehmet Seser. I think he is Turkish. And he said it prefer unilateral microdiscectomy together in an unilateral approach. Bilateral decompression does increase the reherniation. It's a question, I think, for Mehmet Zelili, of course, or maybe for the three speakers.
Increase the reherniation? Why? I couldn't understand that.
It prefer unilateral microdiscectomy together unilateral approach. Bilateral decompression does increase the reherniation, the recurrence.
Yeah, actually,
is a
unilateral approach, bilateral decompression is indicated in central canal stenosis. So then it doesn't increase the reherniation rate. In fact, reherniation is something that is abused by surgeons, I must tell you. Actually, the technique used by surgeons does not predict your reherniation. The reason of reherniation is probably, a big probability is that a kind of instability. So then your technique does not make much difference. But for the lumbar spine stenosis, if you remove all the lamina, I think the same as Keki has described, if you remove all the lamina and spinous process, interspinous ligaments, then the instability risk is increased. So to avoid this instability in the long term, we should better preserve some basic structures of the spine during decompression.
Maybe Professor Nezar, there is some questions in the chat. You can maybe read it.
I have also a question concerning usually this learning curve of for Professor Zelili. You have any education on practical model to in the learning curve, especially in the selection cases concerning clinical pathological data and the physiognomy of the patient? There is any anatomical landmarks to start with the good case in the learning curve, so to avoid especially the conversion to the open surgery during the procedure? There is any educational or practical model? Do you advise us, please?
The best thing is to have a fellowship. I don't think the simulations or the virtual seminars will help you much. It's better to be on the operating room and see the surgeon. There is no other way, especially for minimally invasive surgeries. Converting to the open surgery can be necessary in case of dural laceration or in case of profuse bleeding, probably. I did not make it any time, but it is possible, especially dural laceration, stitching the dura. maybe for that reason it may be necessary. If however, if it is a very small laceration, and if you have used not a large tube like 14 or 16 millimeter tube, then you can place a small fat tissue and a sponge, and then when you remove the tube, the muscles reapproximate, and then there is not much space to leak the CSF. I have done in some cases, very small cases, without stitching, just close the dura, the wound. Nothing happened.
Thank you. There is also another question from the participants, from Dr. Shankar Atwal, from you, Professor Zerili. And the question is, how do you remove the central herniated disc completely with the use of tubular retractor? Some tips, do you do the follow-up MRI to see the completeness of the disc removal, please?
No, postoperative MRI, I don't use it. I don't think any surgeons use it after disc surgery, especially. We don't use it. But for spinal stenosis, you may need it after not just after surgery, but 1 or 2 months later. I want to see if my decompression is good enough. Yes, for lumbar spinal stenosis, I do it. But what was the question? Main question?
Central disc herniation.
Central disc herniation. It is not different than microdiscectomy. It is same. You can do it very well. No problem. The tube surgery is very similar to the microdiscectomy using Casper retractor. Very similar.
I have a question for Kiki.
Yes.
Kiki, all of us, we used to have some patient who all the operation was good, everything is fine. You remove the total, of course, disc herniation, and then in post-operative you have sometimes it's immediately you have pain, and this in that cases usually we know that there's still some pieces of disc that is on this filler. In this matter, I'm completely agree. But when you have some patients come back after 2, 3, 1 month with the same symptom, and that time we use usually the MRI, and there is no explanation for this symptom. What do you advise in this situation? Because it's a nightmare for every neurosurgeon when he had a patient follow him for months complaining about this pain, and there's many situations like that. As an expert in complications, I am asking this question.
So, very good question. The question for me is the pain coming back after getting relieved, or the pain did not get relieved at all from the very beginning? That's important. So if the patient's pain was already relieved and it comes back, it's a different matter. Then it is a question of either adhesions or a low-grade infection. There are two things I would think about. So I would investigate from that point of view. Maybe do a CRP, ESR to see. And if it is delayed recurrence of pain, not continuous pain post-operative. So this is sometimes likely to happen, in which case you treat them conservatively with some rest. Sometimes steroids may be helpful, particularly if there is no infection. They can be helpful. On the other hand, if the patient's pain was never relieved, then you have to ask yourself if your decompression was adequate or sufficient, or whether you have produced instability, or whether you have are not looked at. We may have overlooked instability. And sometimes the pain can come because by removing ligament flavum and not fixing it, and by removing sometimes a medial facet, you are probably causing more instability. So you have to ask yourself what procedure did you do and whether you miss anything. So you should look at your images one more time. And it's possible that some of these patients may require, in that case, fusion at a later date. So
I'm telling about the cases when we, of course, having MRI that shows that there are no recurrence, no disc herniation, no compression, of course, no infection with therapy and everything. It's the cases when you do everything to eliminate all the causes, of course, and even that you have it's still suffering from pain. This is and in my question and in my mind, this is I think this in these cases, I think the indication, the time for indication for disc herniation sometimes is the key for this patient, because when they have suffering for a long time, and there is not only the compression for the nerves, but there is the disease of nerves. This is maybe why this some patients unfortunately is not a lot, but there are small cases like this. I think this is a disease of the nerves, root nerves. This is why they continue to suffer in many. What do you think about this?
I also have one more theory for this. Sometimes it is the brain which keeps thinking that that nerve is still compressed and is still not relieved, and the inflammatory messages. It's not only compression but inflammation that the nerve suffers, and that message continues to remind the brain, and the brain still thinks that the nerve is in distress and imagines that there is pain when actually there is no physical reason for pain.
I agree with Dr. Nejia with regarding this long-lasting pain. This is what we can consider as the deafferentation pain. So the nerve is suffering itself, although
Yes.
the compression is being relieved.
Yes.
And do you think, Professor Keki, that if we make EMG or dynamic MRI, it will be useful for understanding the case of recurrence? Let's take apart the case of neuropathic pain deafferentation. In case of real recurrence, surgery, pain relief, recurrence. This is scenario of, we can think of real recurrence.
Yes, yes, there can, but I think adhesions is one of the things that I have seen in patients. I have not only, I have operated on quite a number of people who have been operated before by somewhere else, and they come back with continuous pain, similar kind of pain, and we find adhesions. I have many videos to show, and adhesiolysis can help, and there is no real way. MRI can give you, but post-operative MRIs are not very satisfying. They don't give you that conviction about surgery, about resurgery. But so you have to go by your own gut feeling that, okay, this may be, sometimes myelogram can be helpful, which when MRI is not contributory. Yes, EMG nerve conduction may also be helpful. So I would say take everything into consideration. Of course, if you're going to reoperate on a patient, you have to think 10 times more than when you went to operate the first time, because a patient who has not been cured by a good surgeon's procedure the first time is a big challenge for you to overcome when you are reoperating on the patient. So you have to think 10 times and be absolutely convinced in your mind what is the cause of this pain, what is the tissue of origin of this pain, from where does this pain come, and maybe you require a pain specialist opinion, maybe you require a neuropsychologist to evaluate all these things. I think before reopening the patient, you have to be very, very judicious. I would give medical treatment, pregabalin or whatever it is. I would try everything else before considering a invasive procedure.
I have a question for Professor Hilmani. There is no question for Kiki.
Yes, I'm
Mr.
ready.
Panelist, May, I can.
No question in the conversation chat. So if one of
have a
the
question. I have a question for Professor Helmani. It's possible to ask him something. I have two questions. First, I would like to congratulate him for this really wonderful talk, overview of all the tumors, of spine tumors. Not easy to summarize, and he do it very well. And my first question is about the plasmacytoma, and he showed us one case is very interesting when he did the open surgery with the laminectomy and fixation and vertebroplasty in the same time. We had a patient with not the same. We didn't have the same strategy, but it's plasmacytoma. So plasmacytoma. It was a diagnosis with, of course, the proof, anatomopathologic proof, and of course with the physician, internist physician who had already treat him with chemotherapy and etc. And he had a small, he had a really a small lesion and one fracture, and we decide to treat him with kyphoplasty, vertebroplasty. But 4 or 5 years after this approaches, he came back with medullary compression, and we used, of course, in emergency laminectomy and in per-operatively. Fahd was with me in this operation. Can you remember? We had removed the cement in intradural canal, and because the disease continued to
spread.
Sorry?
To spread.
Yeah, it continued to spread and push, of course, the cement and in the outside and the canal, and give a compression, medullary compression. This is why I'm now a little bit more. I use less kyphoplasty or vertebroplasty in the plasmacytoma. My second question is about the sarcoma of the wing. Usually, this is this kind of tumor is localized between the between vertebrocostal, and the only and we know that very well. I'm concerning my directly because I had a friend who has who had sarcoma doing 30 years ago, but she had, of course, a radical surgery before chemotherapy and radiotherapy. I think the only way to cure this patient is the radical surgery. Especially in this location is more easier than corporectomy, because we can do it laterally, and it's possible to achieve in the radical surgery. And you show us one of the case where the lesion is localized in the core vertebra, and I think it's in these cases maybe it's more wiser to perform radical surgery and then of course refer the patient to the adjuvant therapy, chemo and radiotherapy. Thank you.
Okay, thank you, Professor Abadi, for those two questions, important and very interesting question. Talk about two tumor which were sensitive, radiosensitive, and sensitive to radiation therapy and chemotherapy. First question, plasmacytoma and vertebroplasty. I agree with you. We must they very careful to use cementoplasty in this area because it's not a very strong region, but vertebroplasty it can be an alternative to en bloc resection. Plasmacytoma it's a very sensitive disease for radiotherapy and chemotherapy. When we use vertebroplasty in this region, we must be sure that cement be placed very anteriorly. Certainly, the posterior wall must be saved, but in some cases, some authors describe even the posterior walls is violated or with extension to without extension into the canal. We can use vertebroplasty, but use it in the third anterior vertebral body with good fusion followed rapidly with radiation therapy. It's very important for this case. For second question, Ewing sarcoma occur in very young and in pediatric patients. On block or total or radical surgery is the best choice, but there is some or many risks for this about these procedures as blood in pediatric loss, very loss, bloody loss and dural or neural damage. Then we can use wide surgical procedure or wide resection followed by vertebroplasty or partial reconstruction. Then it's even this disease is very sensitive to chemotherapy and radiotherapy. With I think that we can alternate this en bloc resection by wide resection followed by vertebroplasty and fusion. Thank you.
Can I make a comment, Nadia?
Yes, the moderator is here. Of course, of course.
Okay. Actually, thank you, Dr. Said Hilmani, for a very nice lecture. But then I have some objections. Actually, the case you have shown for that thoracic plasmacytoma, I would just use probably intralesional RF ablation plus vertebroplasty only, no posterior fixation. Let's pass this, but recently there is a trend among many spine tumor surgeons that instead of en bloc resections, especially for chordoma cases, radiosurgery may be a better option because you cannot predict that there are small seedings which was skipped from the source, main source, to the neighboring area, and then it is big probability that they will recur after a while because you cannot see that small, very small seedings. Second thing, as you have mentioned, I want to stress that especially for eosinophilic, Ewing sarcoma cases and osteosarcoma cases, a pre-adjuvant chemotherapy is necessary. Without that, surgery must not be planned. After a pre-adjuvant chemotherapy, you can plan a radical excision, as you have described nicely, a total spondylectomy or total excision. This is my comments. But total spondylectomy is good for more solid tumors like osteosarcomas, chondrosarcomas, but not very good for chordomas, actually.
Yeah.
Thank you.
There's
Absolutely.
a question from Dr. Bancol. The question is still mandatory to use Tokayashi score for decision making to go for surgery in spinal metastasis nowadays? Thank you, Professor Feman.
Question is for me.
Yes, for you, Professor Femani, about the Tokayashi score. It is still mandatory to make a decision in spinal metastasis surgery.
Okay, thank you, Professor Nizar, for. I think that I say that Tokoyashi or Tomita scores is used for metastasis, but as you show in Boreani scores or Ewing's procedures, the vertebra was divided in the axial plane. They didn't assess the sagittal plane, and in my opinion, we can use this staging for assess or evaluate the extension in sagittal plane into the vertebral above or below the first location, especially in stage 3, where we have the regional or distant metastasis. It's very important, through metastasis. Stage 2 or stage 1 for malignant tumor, we can't use it because it's this intra or extra compartmental only on the vertebral which was with a tumor. But in stage 3, the tumor can be extended other extra compartmental, one vertebral or two vertebral behind the first lesion. I think it's my opinion.
Thank you, Professor Femani. So I think it's no more question from the participants. Ask the colleagues if we can close the session.
Excuse me. Nizar?
Yes, Professor Abadi.
There is a question from one of our friends from Nigeria. You know him very well, Nasiru.
Yes.
He asked that is there is after, of course, invasive surgery, when there is a recurrence, how about the surgery? The question is not really clear, but I think what he was to tell with this. In my ask, Rudus with
my surgery.
I think Nikolai has answered that. It is true. Actually, you can do also reduce surgeries with tube or endoscopic techniques. It's not much different than the primary surgery, but it will be better to get some experience before that, because there are some epidural fibrosis, and the root may be entrapped by the fibrotic tissue, so then you can get difficulty in releasing the root. But it is possible. I do all my radio surgeries with tube again.
Same for me. I also would consider doing revision surgeries in minimal invasive way. But obviously it's not going to be one of the first cases that I would consider when I'm starting some new technique.
So thanks for all the speakers for their wonderful talk, and maybe Professor Abadi will conclude this wonderful webinar.
The turn to Professor Lakhdar. I give him the word.
Professor Lakhdar, if you
not here,
you can conclude this.
He's here, I think. No.
Yes. His mic was mute.
Please, can you?
He's here. He's here.
Sorry.
Yes, we.
There's another question? No?
You're welcome, Professor Lakhdar. You can continue. Yes. 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 to conclude this session, this
Yes,
seminar.
thank you. Thank you all our speakers, Professor Zilili, Professor Tuel, and Professor Hilmani for their wonderful talks. Thank you all the panelists, Professor Nizar Al-Fatimi, Professor Nicola Pil, and Professor Sophie Lisa. And thank you also Professor Al-Abadi for this organization, and Dr. Khawi for all the efforts to organize these webinars. And we give you rendezvous next week for next webinar. Thank you. Thank you
Thank
also
you.
for all the attendees.
I thank you all.
Thank you.
It was wonderful to be with you.
Thank you, everybody.
Thank you.
Thank
Professor.
you. Thank you.
Thank you. And
Thank
so
you again for sharing with you your great experience, Kiki, Mehmet, Nikolai, of course, Sobhi, and Professor Helmani. Thank you so much for this wonderful moment that we speak
Bye.
together.
Bye.
Thank you, all of you. Thank you.
See you soon. Bye.
See you soon. Bye-bye.
Bye-bye.
Bye.
Hein?